Buenas, ¿cómo están? Mi nombre es Juan Granada, cardiólogo intervencionista, presidente del CRF y parte del grupo de Columbia University en Nueva York. La charla que van a ver ahora siguiente es una charla muy interesante que es dada por el doctor Ajay Kirtane de Columbia University acerca del diagnóstico y tratamiento de pacientes con enfermedad coronaria que tienen un alto grado de calcificación. Por muchos años esto ha sido un tema muy controversial porque en realidad los datos no soportan el uso común o frecuente de dispositivos de aterectomía y su beneficio en estos pacientes. Pero a medida que la evidencia se acumula, es muy interesante ver cómo el uso de aterectomía y el uso de métodos diagnósticos se está incrementando. Una de las razones más importantes para esto es el hecho de que se ha visto que hay una progresión hacia eventos cardiovasculares adversos después de la angioplastia percutánea en pacientes con lesiones muy calcíficas por mala expansión del dispositivo, especialmente los stents. Entonces, esta charla es muy importante porque nos lleva no solamente a la parte de diagnóstico, sino también a la parte de planeación del procedimiento y también habla del potencial efecto de estos dispositivos en una mejoría en la parte de procedimientos y de pronóstico clínico. Entonces yo espero que la disfruten, de verdad es una charla muy interesante, es una charla muy completa acerca del diagnóstico, tratamiento y pronóstico de pacientes que tienen enfermedad calcífica severa, las enfermedades coronarias. Espero que de verdad lo disfruten y nos vemos en el próximo capítulo.
Okay, so what we're going to do with this is I'll talk briefly about some of the devices that are out there, some of the ways we need to see things, but then also this will be case-based and maybe we can get some interactivity with the panel as well. So we'll start off with this, and this is an underexpanded stent. And I do want to emphasize to you that this is a real problem. We see it more and more nowadays, and I'll talk about some reasons for why that is. So this was a woman who came in with refractory angina after already having a stent placed in her LAD. And obviously for somebody who comes in, they have chest pain, the stent is placed, they want that pain to go away, they don't want it to keep coming back. And in this case, what I think you can appreciate is the vessel is big, and there's a stent here in the proximal segment, and it's severely underexpanded. Now, this is something you need to train your eye to be able to see over time, but if you don't see it with your eye, the other way to have a clue on this is that an IVUS catheter should cross this, but in this case, the IVUS wouldn't cross at all. So we then further tried with balloons to cross this, and a 2.0 balloon wouldn't cross, and only a 1.25 followed by a 1.5 balloon would then cross. I told some of you yesterday, it is far worse to deliver a stent and underexpanded than it is to not deliver the stent at all. Because once you have the device in there, then that exposes the patient to thrombosis risk as well as restenosis risk. If you don't get there at all, you still have many other options, and it's much easier to atherectomize calcium than it is to atherectomize a stent. So in this case, once you have the situation, there are limited options, and in this case, we tried ballooning. And this is a 3.0 by 15 balloon at 30 atmospheres. You only do that with a non-compliant balloon. We figured, well, if this company's balloon didn't work, maybe we'll try the other company. And no, that didn't work either. 3.0 by 15 at 30 atmospheres 2 times. And so now we really have a problem because this balloon is simply not expanding and we're going to have to do something else. So the question is, how or why did this happen and what can we do about it? We ended up treating it with laser, contrast laser, and it did fine. So the reason it happens is because people underappreciate calcification on angiography. What calcification is you want to see things moving when there's no dye in the vessel. And moderate calcification is usually only on motion, usually on one side. Severe is you see it even on the still frame. If you just cine, you see it and it's on both sides of the vessel. We don't talk a lot about this course at this course about radiation management, but clearly that's important. We don't want our patients or us to be irradiated. But with some of the drops down to 15 frames per second or lower fluoro, you almost have to be more vigilant than we were before because sometimes you may miss it. And if you miss it, that's when you get into trouble like I mentioned. Now, there are other ways to also detect calcium, and you heard about some of this morning. IVUS and OCT are both great ways to detect calcium. So what does it look like? Well, basically on IVUS, the sound cannot penetrate through the calcium, and so you see signal dropout beyond the calcification. So if you see this intense white region followed by nothing beyond it, that's calcium, and we can measure the arc of calcium, and the greater the arc is, the more likely the patient will need to require atherectomy. On OCT, the actual light can go through this, and so you do see not only the calcification here, but the thickness of calcification, and it looks very similar to this pathological specimen. So in many respects, OCT can be a better gauge of calcification because it can give you the thickness, you can see the arc very well, and you don't get dropout. This signal dropout on OCT is lipid, and I know they went over this in the prior session, so I don't want to belabor it, but this tells you that either imaging modality can be very, very useful to detect calcification and can change the strategy that you use. Now, the reason this is important is because with an aging population, with more downstream access to the cath lab, because as I talked about yesterday, we're no longer cathing those, BS stress tests that don't need to come to the cath lab. We're only cathing more and more severe patients. You see that there's a greater frequency of heavy calcification. This is within the Syntax trial. There was 50% of patients had heavy calcification in this trial of multivessel disease. And as we have more renal failure, more diabetes, the age goes up, the incidence of coronary calcification gets greater and greater, and that's important for us as interventionalists to recognize. So if I see a patient that's post-CABG, or I see a patient that has renal failure, in my mind, immediately as going into this case, I'm thinking this is going to be calcified. And if I don't see it angiographically, I potentially consider doing imaging just to be sure that I'm going to know how to treat this effectively. So what does calcification do? I think everybody knows that it makes the case tougher because it's harder to push your equipment in and out. But as fellows, we often fixate on that aspect, getting the equipment in and out. And as I said before, that's only part of it. If you get the equipment there and it doesn't expand, you get through the case acutely, but that's really bad for the patient long term. We also know there's more dissections, perforations, and by the way, increased rates of stent thrombosis and restenosis. This is just an example of a recent study that just got published in CCI showing that if you have severe calcification, the event rates are above 20% at 1 year. So among the lesions we treat, these are sort of the highest risk lesions for restenosis and thrombosis in a sense, compared to pretty much anything else we do. Vein grafts is probably the other one. So this is one of those things where normally if a patient you see in the office and you tell them, yeah, you have a 5% chance of coming back in the next year, well, that's not true if they have severe coronary calcification, and that's why it's important to know how to deal with it. So the importance of what we do, I mentioned, but how do we treat it? Well, we have to modify the plaque. That's the most important thing to do, but also we want to expand the lumen, and usually we expand the lumen by modifying the plaque. With most techniques. So what that does is that allows us, yes, to get our equipment there and to get the case done, but it also allows the stent to expand further, and by modifying the plaque specifically, it also avoids indiscriminate expansion of balloons, which is kind of like, it's like flipping a coin. It might expand or it might perforate. It might expand in the area you want it to, or it might expand longitudinally with a dissection. So that's one of the reasons why there are plaque modification strategies specifically designed for calcification to do this in a more controlled setting. These are just some pictures of what can happen. This is abrasion of polymers, and Greg showed some of this yesterday. So if you have a DES and you do this to the polymer or you do this to the stent, it's clearly not going to be effective, and that's one of the reasons why you want these cases to be smoother with typically plaque modification strategies. So one of the ways that we can determine whether we need to do it or not is to look at the arc of calcium, the length of calcium, and the thickness of calcium. And this is an OCT-based scoring system that our group and the St. Francis group put together, basically showing that if you have an angle of calcification greater than 180 degrees, if it's thicker than, or so basically half 50%, if it's thicker than 0.5 millimeters, and if it's greater than 5 millimeters, so rule of 5, 50%, 5% thickness, or a 5 millimeter length and 0.5 millimeter thickness, then those are cases that are going to need atherectomy for the most part. And the reason that atherectomy works, and this is really fundamental knowledge for you as fellows, is it's not because you're getting rid of the plaque only. In fact, the reason atherectomy works is that plus the fact that you form cracks in the calcium, and that allows your vessel to expand. Because if you had a concentric tube and you just got rid of the stuff inside it, well, you're only going to be able to expand to the diameter or radius of that tube. If you fracture the calcium and make a hinge point like this, then the entire tube can expand, and that's how you get expansion. And this has been shown in really nice OCT and OFDI studies, that if you get the development of a crack, those are the cases where the stent will expand the greatest over time. So what are our options? We have NC balloons. Remember, we don't want to use compliant balloons for what Dwayne talked about yesterday. You don't want the dog boning effect, where you're going to basically expand in the non-calcified region and potentially perforate and not expand in the calcified region. So a non-compliant balloon will expand uniformly throughout. You can take balloons like the cutting balloon, the angiosculpt, the chocolate balloon, which are kind of focus force balloons aiming to expand only in those regions. And then you can do atherectomy as well. And then there are newer things that you'll be seeing soon, like lithotripsy. So this is just one strategy for approaching it. I think most of us generally follow this kind of an algorithm. If you don't see very severe angiographic calcification and your risk is not that high, then typically you'd go with a balloon-based strategy. If you see severe calcification angiographically, most people will go atherectomy. And if you're somewhere in the middle, that's really where imaging can help. So we pretty much image every single one of these cases. Sometimes the imaging catheter won't cross up front. That's a poor person's way of knowing that there's severe calcification. If the imaging catheter doesn't go, there's a problem, and think about atherectomy in those types of circumstances. There are different tools that we have. The Rotablator was first approved in 1993, so it's really going on quite a fair amount of time. There are exhibits, so you'll be able to see what it's like. Basically, it's a diamond tip burr. It doesn't have a burr on the back end. There's a drive shaft, and it makes a lumen that is basically the width of the burr itself. It will form cracking, though, as you get more and more wire bias. Orbital atherectomy is a newer system. It was approved a few years ago. This has it sort of can go on both sides and abrade calcium on both sides. There's a handle here. Remember, Rota was just recently updated, so there's now a version that has a handle that's similar to this. But for Orbital, there's a handle here, and the orbit difference from Rota is that it actually orbits in addition to going in the straight line, and so perhaps you can get a larger lumen with that, and that's why there's only need for one burr as opposed to multiple other burrs. Other techniques and technologies that you will soon be hearing about, this is coronary intravascular lithotripsy. This is a balloon that with ultrasonic waves creates these shock waves and cracks in the calcium, particularly if it's concentric calcification, and that then allows stent expansion. And so this is something that's currently being studied here in the United States, and you'll see more soon. So let's get into a couple cases that will describe some of these issues. This is a patient that had anterior septal ischemia, there was chest discomfort, and here's the angiogram. And if you look here at the LAD, I think you can appreciate that there's calcification seen here on the LAD, and there's a lesion distally. Many of you would just focus on this part distally alone, but in fact, let me go back a second. There's actually disease through the proximal segment as well that needs to be addressed, because this is your inflow into your stent. So this is the tightest lesion, yes, but there's disease all the way back through here. So maybe I'll stop for a real quick second. On the panel, Nick, how would you treat this? You have many options here. What would you do? Can you turn on the mic here?
Start with imaging to see what you're dealing with first.
So that's never going to be wrong with that answer. The imaging catheter might not cross, especially the tighter lesion, but at least it'll give you a look at some of the proximal stuff. The truth of the matter here is we actually don't know what the best strategy is. We think we know. If it's severe calcification, we think that atherectomy is the right thing, but we actually don't know the answer to that. And so this patient was randomized in a trial that we're running called the ECLIPSE trial. Basically what that trial is 2,000 patients, and in a case just like this, because this case was randomized, where you don't know what the right strategy is, they're randomized to orbital atherectomy versus conventional angioplasty. They get dilations and then PCI, and the follow-up is out to imaging, and then follow-up out to 1 year for target vessel failure. This is what the final angiogram looked like. This patient was actually randomized in the balloon strategy, OCT guided as well. And I think you can appreciate that at that tight area, there is a little residual stenosis. And that's one of the reasons why we're doing this study, is because we want to know, is that residual stenosis more apt to happen with balloon or atherectomy, and does that have clinical consequences? So there'll be more to come on that trial going forward. This is another case of a nasty LAD with calcification. I don't think it looks that calcified down here, but up here there is. And I would say in general, as a rule, when you see this degree of disease, just nasty type disease, think calcification. Because you don't generally get that degree of atherosclerosis unless there's some, FH or something like that without having coronary calcification as well. And so for this type of case, what you first do is you try to cross with a wire, and in this case, your workhorse guide wire did not cross. Another hint to you, there's calcification there. We then cross with another wire, and then the question is, how do you treat this? Do you go with balloons? Do you go with something else? So, Dimitri, what would you do? Is this a balloon case first, or what do you think?
Well, I think that this case screams atherectomy, so I would go ahead and rotablate it. Actually, you can get a lot of information in addition to what wire crosses by how much, how it behaves when you go through this tortuosity and calcium. So as you get to the stiffer part of the wire and you start seeing your guide getting pushed out or the wire is not moving the way it is, that's another hint that you're dealing with a calcified lesion. So in this case, I would go with Rota probably.
Yeah, that thing that he mentioned, as you're pushing the wire and advancing the wire, you generally don't push a wire, you're kind of letting it go. If you lose your torque control in a vessel and it's not severely tortuous, there's two reasons that happens. There's a lot of tortuosity or there's a lot of calcification. And so oftentimes in our cases, sometimes, the fellow may wire it, but they'll ask to feel the wire and just know what's going on because that's a real clue of what goes on after that point.
The other thing that would be concern to me in this case here is it looks like the right coronary artery was occluded. And when you always do atherectomy, you always have to think of your micro emboli going to a contralateral vessel. So if this would be one of those that if the right coronary artery could be opened first, it may make a safer atherectomy.
That's true. And so in order to do atherectomy, you need to have an atherectomy wire that's specific to the system down. And so the way that you get that wire down is you exchange it over a microcatheter. And so this is just an example of a microcatheter coming down the vessel. And then after that's down, in this case we had to use a different microcatheter because the first one wouldn't cross. After that's down, it's time for atherectomy once you exchange. And so this is the wire coming out. Now, one thing I will point out to you is that when you put the atherectomy wire back in, you don't want to just push it out the end of the microcatheter because you can perforate a vessel. And so I'll show you how this is done. This is the atherectomy wire coming up the aorta. It's then going to come around through the guide down, and then you'll see it slows down because what we're doing is we're pulling the microcatheter back as we're gently letting the wire go forward. So we're unsheathing the wire so as to not poke into something else. And that's generally good technique. You don't want to lose your position distally, but you don't want to just poke a wire out of a catheter. And that's true not only in the coronaries, but it's also true, in the arm, anywhere else that you advance wires after that. So atherectomy is performed. We did rotablation here, and then we exchanged for a stiff wire because still, even if you do atherectomy, there's going to be difficulty delivering stents through this tortuosity and these spicules of fractured calcification. And so we use the wiggle wire in this case, and that's a wire that sort of anchors things distally. And then you have to balloon. It's not enough. If you may see attending do atherectomy and stenting immediately after that. That, in general, is technique that we would frown upon. You have to make sure the balloons expand before you put the stents in. And so we protect the diagonal, we then balloon, and the balloon does seem to expand. It seems to expand proximally as well, but we don't just take, the visual word for that. We actually will do more, and so this is when we IVUS. And so with intravascular ultrasound, I'm not going to go through the entire run, but we basically IVUS to see that the balloon was expanding in these areas. We're looking for calcification fractures as well. I'll admit that it's actually better and easier to see this with OCT than with IVUS, but you sometimes can see fractures on IVUS as well. But after the IVUS, then we feel comfortable trying to put stents in. But even that, with the tortuosity, it's going to be difficult. And so we had to balloon this more aggressively, which does expand, and ultimately use the guide extension catheter to deliver our stents. So these calcified cases, it's not just doing atherectomy, it's knowing the whole toolkit, microcatheters, guide extensions, the right guide, the right support, as Nick said, making sure you know the other anatomy. If you look at this guide here, it's way out here because the guide comes out when you're pushing against resistance in. And in order to get the guide extension here, the way we did this is we inflated a balloon here, and then we're able to push the guide extension down. With the guide extension to this point, we then can deliver stents. And you don't want to do this until you know they're going to expand. But with expansion, that's the first stent. The second stent was done. We used IVUS again, post-dilated, and this was the final result. So that's just, a case that takes you through a little bit more complicated at what you need to do for these patients, because we're competing essentially with surgical revascularization. And if we don't do this right with good expansion, we're never going to achieve those types of results. So the final case I'll show you is a 69-year-old gentleman comes in with worsening exertional angina, no rest symptoms, troponins were mildly positive, and comes into the cardiac cath lab with this EKG. Pretty abnormal. The anterior R waves are minimal to absent. The echo, actually the patient was on the floor for a day and had an echo that showed an EF of 20 to 25% with anterior septal apical akinesis but no thrombus, and the remaining walls were variably hypokinetic. So for these types of patients with a depressed ejection fraction coming with a dead anterior wall, we are clinicians, not just technicians, and so we do right heart catheterizations to help understand what the hemodynamics are. And so these were the hemodynamics. At the start, the PA sat was 66, but the blood pressure was somewhat marginal. This is what the cath shows. So the LAD is not visible. The circumflex is not the hugest vessel, but that's actually all right. Here's more, and you can say, well, how do we do the right heart cath? Because this is a radial case. Well, we do routine brachial right heart caths. It's very easy for the patient. They can sit up. It's actually better for the patients that are in florid heart failure because they can sit up. And so this is what we saw. And this is the right coronary. So it looks heavily calcified. There's dye there, there's contrast appearance, or you can see the vessel before we inject. And there's this lesion in the right coronary, which is essentially supplying most of his heart. So what do you do at that point? Well, what you should do in this case is assess what you need to do. And so we actually took the patient off the table because they were stable, and we confirmed there was no viability in the LAD distribution. Because if there was viability, then this is a patient that you would either want to think about doing the CTO or surgical revascularization just based on stitch and other trials like that. And all other walls are viable. So maybe I'll ask, Cindy at this point, how would you do this case, and what would you be worried about? What do you think?
Well, I don't even know how to interpret viability studies after the stitch trial, right? Because people who had no viability actually had improvement with bypass surgery. So I still might get the heart team involved. But if, say, we're going to do a PCI, I think that I'm a bit concerned about hemodynamic decompensation. You're basically working on almost the single remaining vessel, right? I mean, the circ is not big. This is a huge hyperdominant right coronary artery, and so I might use hemodynamic support for this particular case. I would probably go ahead and image it as well, because it seems like there's a ton of proximal calcification, and at the lesion itself, it actually looks almost ulcerated, right? It looks like a combination plaque, and so I'd like to see that in greater detail using imaging.
Yeah, no, I think that's exactly right, and those are the things we were concerned about. We definitely did get the surgeons to see the patient. From the stitch component, that's why we don't do thallium pretty much anymore. It's mainly PET or MRI, but even that you can argue, see. But I think with no viability or sort of nothing up on PET in the anterior wall, it's pretty reasonable to leave that alone. We were very concerned about decompensation of this patient, especially if we were doing atherectomy of the right. So the setup was radial and then ultrasound-guided right femoral access. You can see here there's a multi-purpose coming up from the radial and down, so we can confirm where we are if we didn't want to do it with ultrasound, but we're pretty comfortable doing it with ultrasound. We have a right heart cath in as well. Why do we repeat the right heart cath? The reason is because when we use hemodynamic support, we like to monitor the hemodynamics real time. And what happens is when you put in, for instance, a percutaneous LVAD like an Impella, you eject everything out of the left ventricle, and patients can get hypotensive, and you don't know if that's because they're dry, because the left ventricle is empty, or for some other reason. And so we keep this swan in the entire case and monitor it during the case. The other thing that can happen is if patients get really ischemic during the case, PA pressures will go up, and you'll be able to see that before they start coughing and going into pulmonary edema. So in this case, this was the Impella device was in. There's a big loop here, so did need to wire this with a stiffer wire, or put a guide in with a stiffer wire in place. This is the radial access with an AL, and I didn't want to put an imaging catheter down and make things worse initially, so decided to just atherectomize this. Crossed with a wire, and to Dimitri's point, the wire actually crossed pretty easily. The microcatheter crossed pretty easily, exchanged out for the atherectomy wire, and in this case did orbital atherectomy. We didn't really hear the feedback. You hear the noise when it's ablating, and you'll hear the change pitch. Didn't really hear that, but the atherectomy went fine. So I was a little confused as to what was going on. And I still remember I took a survey of the attendings in the cath lab before this case and asked people, is this calcium or thrombus? And I think it was like 80% calcium, and there were a couple, well, it could be thrombus as well. And just like Cindy said, it looked potentially ulcerated. So we do OCT, and there's thrombus, and all the calcium proximally is more very, very deep wall. And so in actually this case, we should have imaged first because we might not have needed to do atherectomy. This was all thrombus. So did thrombectomy at that point. Basically, just to fast forward through this, after thrombectomy, then pre-dilated because there is calcium there, 3/0 NC, and then put a 4/5 DES in. That's what that looked like. And this is the final result with great apposition, great expansion, and that's what it looks like. So the imaging is really, really key in this case. I still think even with thrombus, I would have considered doing hemodynamic support because if that embolized, it would have been really problematic for the patient. These are the hemodynamics, emphasizing the point that even though we did this safely, the hemodynamics decrease, the index drops a little bit. We make people worse when we do PCI because we're ischemic with balloons and the devices we use, and that's one of the reasons for support. What we do in these cases is I had the radial access, the multi-purposes here, dry field closure to be sure that everything's fine because the complication of a 14 French sheath is something that shouldn't be taken lightly. So just to conclude, coronary calcium, more and more prevalent in the modern day cath lab and the CHIP era, aging population, multiple comorbidities, and downstream presentations of disease after medical therapy has failed. These lesions are among the highest risk lesions we treat. They cause short-term pain and suffering in the lab and risk to the patient. So it's bad for both the doctor and the patient. Longer-term outcomes are clearly worse with severe coronary calcification. We feel that imaging is a must, and it's important not only for the diagnosis, but the treatment algorithms may differ, and I think you're going to see more and more of this. If it's nodular, you may treat it differently than if it's circumferential. If it's deep, you're going to treat it differently than if it's superficial. And after initial lesion preparation and prior to stent implantation, these are the times when you really want to use it. It's also important to use it after you put the stent in to be sure your stent is optimized and to get your best outcomes. And the field of adjunctive therapies for calcified lesions, it was dormant. It was literally ossified and calcific for a long time. But now, with newer devices, newer technologies coming in, there's more and more data, there are more and more studies. And